Superficial vein thrombosis, often abbreviated as SVT, might sound like a minor issue, but it carries significant implications for patient health. While many might consider it a benign condition, new insights reveal a more complex picture, emphasizing the importance of accurate diagnosis and appropriate management. This nuanced understanding is crucial for clinicians looking to optimize patient care and prevent potentially life-threatening complications. One of the most striking findings highlights the immediate danger. Approximately 25% of patients with lower extremity superficial vein thrombosis are found to have a concurrent deep vein thrombosis, or DVT, at the time of their diagnosis. This isn't just a coincidence, it underscores the close relationship between superficial and deep venous systems. Furthermore, up to 10% of these patients may progress to develop a new DVT or a pulmonary embolism, making the initial SVT a critical warning sign that should never be ignored. Distinguishing between superficial vein thrombosis in the upper versus lower extremities is also vital, as their origins often differ significantly. Upper extremity SVT is most commonly iatrogenic, meaning it's caused by medical intervention, often due to indwelling peripheral IVs and PICC lines. In such cases, the primary step in management is straightforward: remove the offending catheter if it's no longer medically necessary. Lower extremity superficial thrombosis, however, frequently presents alongside other conditions, most notably varicose veins, which are present in nearly half of all cases, and chronic venous stasis. Perhaps one of the most critical and counterintuitive insights revolves around diagnostic testing. The D-dimer test, often a go-to for ruling out DVT, proves unreliable for superficial vein thrombosis. Its sensitivity ranges only from 48 to 74%, which means a negative D-dimer cannot reliably exclude the diagnosis of SVT or the risk of its extension into deeper veins. Therefore, clinicians should avoid using D-dimer in the diagnostic algorithm for SVT, as it provides a false sense of security and can lead to missed diagnoses. The most critical factor in determining the need for anticoagulation hinges on two key measurements: the length of the thrombus and its distance from a deep venous junction. This precise assessment guides the treatment strategy. Thrombi measuring less than 5 centimeters and located a significant distance from a deep venous system can often be managed conservatively, focusing on symptom relief. For these lower-risk cases, conservative management typically involves a multi-pronged approach to alleviate discomfort. This includes symptomatic relief with NSAIDs, which can be taken orally or applied topically, along with the use of warm compresses and compression stockings. These measures aim to reduce inflammation and discomfort while supporting venous blood flow. However, specific criteria warrant more aggressive intervention with anticoagulation. For lower extremity superficial thrombi that are at least 5 centimeters long, but still greater than 3 centimeters away from the saphenofemoral junction, anticoagulation is recommended to reduce the risk of venous thromboembolism. Available options include fondaparinux at 2.5 milligrams subcutaneously once daily for 45 days, a regimen supported by the Callisto trial. Other considerations are rivaroxaban 10 milligrams once daily, as explored in the Surprise trial, or enoxaparin 40 milligrams daily, which is a prophylaxis dosing. A superficial thrombosis located within 3 centimeters of a deep vein junction represents a high-risk scenario that demands therapeutic dose anticoagulation for a minimum of 3 months. This aggressive approach is necessary because of the substantial risk of the clot propagating into the deep venous system, essentially becoming a DVT. In these instances, the treatment mirrors that of a true deep vein thrombosis due to the high potential for serious complications. Finally, certain presentations of superficial vein thrombosis should raise immediate red flags, prompting a comprehensive workup for underlying systemic conditions. The presence of bilateral superficial thrombosis or migratory thrombophlebitis strongly suggests an underlying malignancy or a prothrombotic state. Trousseau syndrome, for example, is classically associated with pancreatic cancer, highlighting how SVT can sometimes be the first outward sign of a more serious hidden disease.